Before starting the session, I would request everyone, while you are talking, kindly switch on your video so that we can see you. And while someone is presenting, I would request everyone, as this is a meeting, kindly keep yourself muted so that there is no chaos during the presentation. So for the time being, I'm muting everyone. You are having the authority to unmute yourself while you are talking. So let me first unmute all of you. Okay, now I will be starting with the Clearnet video, then I will hand over the session to Dr. Prashant Shankar. A very good evening and a warm welcome to all the doctors present here. This side, Debolina from Clearnet, and I would like to welcome all the doctors who are present here. Clearnet is India's largest live digital CME and a doctors-generated medical content platform, which is exclusively free for all the medical practitioners. So now with all of you, I am going to share a short glimpse of Clearnet. Kindly give me a minute. I'm sharing my screen and I hope it is visible to all of you. Thank you so much, all the doctors, for your patience. Our website is www.clearnet.com. There we have lots of live sessions conducted by eminent speakers across the globe. Besides, we have MedWiki services, which is medical Wikipedia for doctors only. That also you can read in your leisure time. So without now further ado, I would like to hand over the session to Dr. Prashant Shankar sir to start with our today's session. Sir, over to you.
Thank you, Debolina. Very good evening to all, and welcome to the 8th episode of Diabetes Crossroads, which is an academic module, monthly academic module, which is run by the Kerala chapter of Rssdi. And we have been covering various aspects of diabetes in the previous sessions, right from the pathogenesis, the microvascular complications, the screening for complications, the management, the non-medical management. And now we are into the macrovascular complications, where first we are dealing with diabetes and the heart. So we have our chairperson, Dr. Chandni, along with us, and Dr. Suresh Kumar, who is our secretary, and our treasurer, Dr. Anita Nambiar. Suresh sir, I would like to have a few words from you before we start off.
Yeah, thank you, Prashant. Actually, we are into the 8th episode of Diabetes Crossroads successfully running, and thank Dr. Prashant for conducting this successfully. This time we have a little. We have just deviated from the usual course by interesting somebody else, that is Clearnet, as you notice now, just as a trial. Excuse me, Clearnet, this is only a trial version. It's not a permanent handing over of our CME to you anyway. This time, suppose if it has been run successfully and we are convinced, we'll continue to do this platform itself. Otherwise, we'll go back to our usual conventional Zoom meetings. Yeah, that's what I just wanted to tell this time. Now, thing is, we have the most sought after speaker this time with us, Dr. Govindani sir. As last time when we were talking about the hunting for the speaker for finding the speaker for diabetes and heart, most suggestions came as Dr. Govindani sir. And now he was a little worried whether this is the third time in a row, continuously he's with us. But it is an honor, sir, for us that you are with us, and we are happy to have you here. And I think most of us we are going to enjoy the academic activity that is going to be shared by Clearnet. And without wasting much of time, I thank all those people who have participated and those who are going to log in for associating with us and for encouraging us for this academic activity. After this this event is over, the recorded version of this particular version will be available on the YouTube as well for you to watch. Anyway, with these few words, I thank Clearnet for conducting this event this time, and also thank Dr. Govindani sir for consenting to be with us. And I thank Prashant Shankar, Dr. Anita Nambiar, Dr. Shantini, everybody for making this possible. Thank you very much. Thanks a lot.
Thank you, sir, for your words of introduction. So we will now go into the meeting. I once again welcome all those delegates who are joined in late. And I will be introducing the chairpersons. And then I will be handing over the session to the chairpersons for the rest of the meeting. So we have two eminent physicians as chairpersons today. So the first chairperson is Dr. Sonia Suresh, who is currently working as a consultant physician at VSM Hospital, Mavelikara. She has got almost 2.5 decades of practice in Mavelikara, Kayangalam, and nearby areas. And she also has books in Malayalam and by the Kerala Bhasha Institute, and one on diabetes and one on geriatrics. And she also has got a lot of videos in the YouTube and majority on diabetes and allied topics. And she also has got, she also runs a Preeti clinic, diabetes clinic in Mavelikara. And she is currently the president of IMA Mavelikara. And she's somebody who is very close to me because she was the person whom I contacted almost a decade ago before starting a diabetes clinic in my hospital, in the hospital where I work. So I have some close attachment to Dr. Sonia. Next chairperson is another close friend, Dr. Shibin Sudevan, who is currently working as the consultant physician and diabetologist at Pulse Clinic and Avitis Hospital, Palakkad. And Dr. Shibin has got a cumulative experience of about 15 years in the field of internal medicine and diabetes. He has a keen interest in the management of lifestyle diseases like diabetes, hypertension, cholesterol, and obesity, and stress-related illnesses. He had his MBBS from Calicut Medical College in 2002 and MD Medicine from SMS Medical College, Jaipur in 2008. And he also has his postgraduate diploma in diabetology from Amrita Institute in 2011. And again, Dr. Shibin is popular in the social media, in Facebook, with his videos educating the people, making people think about various aspects of diseases and like diabetes and hypertension. So I welcome both chairpersons to this meeting, and I hand over the session to them for conducting the meeting from here on.
Good evening, everyone. I hope I'm audible and visible.
Yeah. Yes.
Yeah. A very good evening to everyone. It's a pleasure and privilege to be here, chairing this session. It's a very important session in this diabetes crossroads talk of Rssdi. I thank the office bearers of Rssdi for this opportunity. This is a very important session because of the very fact that actually the major mortality and morbidity due to diabetes is actually due to cardiovascular disease. So today's topic is actually dealing with that. When I think of diabetes at heart, you can say it's actually a disease of doubles. Diabetes actually doubles the risk of heart disease. Every 2 ISD patients that a cardiologist sees, one is definitely a diabetic. Diabetes is said to be a coronary risk equivalent. So if you have diabetes and if you have a heart attack, you actually have a double heart attack. And for every diabetic, you actually have to be double careful because there is something called a silent ischemia, which actually can go miss. And for cardiologist, actually, it's again, he has to be double careful when he's doing an intervention because there is a high chance of restenosis or reocclusion when the patient is a diabetes. So from our eminent speaker, Dr. Govindran sir, we are actually expecting again 2 things. One, primary prevention of cardiovascular disease and diabetes, and secondary prevention or management of the person who has already had a cardiovascular disease. And sir, actually the saying goes, he makes things as simple as possible, but not any more simple. His talks are always, concise and to the point and very easy to understand. So without much ado, I actually hand over to Dr. Sonia Suresh for the introduction of the speaker. Thank you.
Thank you very much, Dr. Shibin. It's a pleasure getting associated with Rssdi Kerala chapter. Thanks to Dr. Prashant, Dr. Chandni, Dr. Suresh, and Dr. Anita for letting me be a part of this august forum. It's my pleasure and privilege to introduce Govindan Unni sir. Actually, he's a person at whom we've been looking with a lot of awe all these years. So he's a first rank holder and best outgoing student for MBBS from Calicut University. Delivered Calicut Medical College Alumni Annual Oration. Is recognized as an inspiring cardiologist by Economic Times Conclave in 2018. Regular faculty at annual national meets of Cardiology Society of India, Indian College of Cardiology, Hypertension Society, and Association of Physicians. Teaching faculty at several CMEs conducted within India and outside. Recognized PhD guide of Kerala University of Health Sciences. 38 publications, including 4 chapters in textbooks. Part of major studies, including those conducted in India and outside. He is currently the professor and medical director of Jubilee Hridayalaya, Jubilee Mission Medical College and Research Institute, Thrissur. It's my honor and pleasure to invite you, sir, for this CME. Over to you, sir. Thank you.
Okay, thank you. Thank you, Dr. Sonia and Dr. Shibin. Let me also thank Rssdi and the office bearers for giving me this opportunity. And my thanks are due also to Clarinet for giving this platform for giving this talk. Well, my talk today is, as has already been said, is diabetes mellitus and the heart. Now, if you look at type 2 diabetes mellitus from the pathophysiologic point of view, most people will say that diabetes mellitus is a disease of glucose metabolism, which is only partly true because diabetes affects lipid metabolism, protein metabolism, and many other things, part of which we know and many probably which we do not know. But that is theory. Forget about the theoretical aspects. When you come to the practical diabetes mellitus on the ground, clinically, diabetes is actually a cardiovascular disease with some amount of hyperglycemia also. Now, why I say this is because even before hypoglycemia sets in, as I will show you after some time, even before hyperglycemia sets in, even in pre-diabetes, there is an increased incidence of cardiovascular disease. So I would say from the clinical point of view, the diabetes is actually a cardiovascular disease associated with hyperglycemia. As already mentioned by the chairpersons, 65% of all death in diabetes mellitus are due to cardiovascular diseases. There is increased risk, 2 to 5-fold increased risk, not only angina and myocardial infarction, but also heart failure. And heart failure is going to increase now because our treatment of angina and myocardial infarction has improved. So maybe heart failure and renal failure are the things that we have to be more worried about now. Now, again, somebody already pointed out, I think Dr. Shibin, that diabetes is considered a cardiovascular risk equivalent. This is because of a study long ago, 1998, published by Hafner in New England Journal of Medicine. What they did was that they plotted cardiovascular event rate, the incidence of heart attack or stroke during a 7-year follow-up. Now, you can see this is the event rate. The yellow is patients who have no diabetes, and the red is patients who have diabetes. So you can see in people who have coronary artery disease, those with diabetes has a much, much higher event rate compared to those with CAD but no diabetes. Now let us look at those patients without CAD, and you can see that those without CAD and without diabetes have the lowest event rate, whereas patients with no CAD but having diabetes, that the red is having an event rate which is almost equivalent to those patients who have a CAD but no diabetes mellitus. That is why Hafner coined the term cardiovascular risk equivalent. But that was in 1998. And subsequently, we have the REACH registry, which actually showed that the CV risk of a person with diabetes without additional risk factors is in between that of an individual without diabetes and someone with established CV disease. So diabetes is not actually a coronary artery disease risk equivalence, it is slightly less. So what is the reason between these two trials did in 2 different years, in 2 different centuries actually, because one was in 20th century and the other in 21st century? The reason is very simple. The diabetic cohort in the REACH registry had a much greater adherence to statin therapy. So the minute you give statin to a patient with diabetes, his risk comes down to less than a CSD risk equivalent. Or putting it in another way, the diabetes cohort who is not on statin therapy is a coronary artery disease risk equivalent. The risk of cardiovascular disease in those diabetic people who are not on statin therapy is equivalent to that of an individual with known coronary artery disease but no diabetes. That is a coronary artery disease risk equivalent. Whereas patients who are on statin therapy is between a patient with coronary artery disease and somewhere without coronary artery disease. Now, this has been proven subsequently also in the Danish population study, the Million Women study from Europe, which are all prospective long-term studies in the general population, which proved that it is statin that has made all the difference of CSD being a risk equivalent, now being considered not, it is a little less than a CSD risk equivalent. As I said, blood sugar is only an incidental finding as far as coronary artery disease is concerned, because even pre-diabetics have increased incidence of cardiovascular disease. Now, if you look at people who are not diabetic, non-diabetic throughout the study, if you look at the relative risk as 1, even 15 or more years before diagnosis, they have a 2.5 times risk of developing cardiovascular disease, myocardial infarction or stroke. And 3.19 times the risk if you take 10 to 49 years before, 14.9 years before diagnosis of diabetes, and 3.64 times the risk if you look at less than 10 years before diagnosis, which tells you that actually, even though blood sugar comes up only at one point of time, the risk for coronary artery disease actually comes much, much before blood sugar goes up. And that is what is known as the ticking clock hypothesis. Because you know, hyperinsulinemia is there for a long time before blood sugar starts going up. So it is very important to understand that also. As already said, cardiovascular diseases are the major cause of morbidity and mortality in type 2 diabetes mellitus. It is the largest contributor to the direct and indirect cause as far as treatment of diabetes is concerned. And among these risk factors, hypertension and dyslipidemia are probably very clear because there are data after data showing that controlling these individual risk factors includes increases the efficacy of preventing cardiovascular diseases. And when you look at multiple risk factors together globally, the benefits are actually multiplied, not added, but multiplied. If you control hypertension, control dyslipidemia, stop smoking, regular exercise, weight reduction, put everything together, and you have immense benefits as far as CV risk reduction is concerned. Now you can see this is the red is patients who have no diabetes, matched cohort, and the blue is patients with diabetes. If you look at the mortality from any cause, from 1998 to 2014, the mortality rate has come down in the matched cohort, but in diabetes, you can see it came down to about 2004, 2005, but subsequently it has been remaining stable. We have not been able to bring down the mortality in diabetes mellitus. If you look at specific causes like cardiovascular disease, you can again see diabetes have a higher rate of cardiovascular disease compared to matched cohorts, and it continues up to 230. The story is the same if you look at death from coronary artery disease is concerned or hospitalization for cardiovascular disease is concerned. In all these situations, diabetes have a higher rate compared to matched cohort, and it continues over the years in spite of all the progress that we have made in treatment of diabetes, in prevention of coronary artery disease. You can see that the gap persists. It is almost parallel. The two lines are almost parallel. And hence, risk stratification or cardiovascular risk stratification of patients with diabetes are essential. Now, Dr. Shibin said that he would like me to talk about primary and secondary prevention. But let me tell you that many diabetes are high risk, and quite a good number of them are very high risk, with the result that the concept of primary versus secondary prevention is blurred if you look at diabetes. Many of the high-risk patients are as good as secondary prevention. If you look at the definition of very high risk by the European Society of Cardiology, it is patients with diabetes and established CVD, which means secondary prevention, plus patients with diabetes and target organ damage, which means no established CVD, primary prevention. 3 or more major risk factors, again, primary prevention, or type 1 diabetes of more than 20 years. All of them are primary prevention, but considered to be very high risk, equivalent to secondary prevention. High-risk patients are diabetes more than 10 years, no target organ damage. If there is target organ damage, it shifts to very high risk. Or someone with any other one additional risk factor. And moderate risk are the very rare young patients, less than 35 years or less than 40, 50 years with no other risk factors and diabetes duration less than 10 years. So you can see that the vast majority of diabetic patients that you and I are going to see in the clinic are either high risk or very high risk. And a few fortunates are in the moderate risk category. And there is no low risk as far as diabetes is concerned. All are at least moderate risk. So if you want to prevent ASCVD and heart failure, I am insisting on heart failure because that is going to be the real threat that we are going to face now in the next decade or a couple of decades. The most important thing is to assess the CV risk factors, at least annually. This year it may not be there, but next year you have to do. Every year, assess the CV risk factors systematically. And then treat the abnormal risk factors which are modifiable. Concentrate on the modifiable risk factors. What are the modifiable risk factors? Obesity or overweight, hypertension, dyslipidemia, smoking, chronic kidney disease, not totally modifiable, but still some amount of modification. Albuminuria, again, not totally modifiable, but still you can treat albuminuria also. And then, of course, there are the non-modifiable features, which are the duration of diabetes and the family history of premature coronary artery disease. Lifestyle interventions, of course, is the foundation for any treatment and prevention. Includes no smoking, most important, at least 150 minutes of aerobic activity weekly, which will translate to 30 minutes, 5 days a week, weight control, healthy diets. Pharmacological strategies include control of blood pressure and control of LDL cholesterol. Remember, I have stopped with LDL cholesterol because now there are no pharmacological strategy to increase the HDL or reduce the triglyceride that have shown to prevent coronary artery disease. So as far as lipid profile is concerned, right now, only LDL cholesterol management. Benefits of glucose control, on the other hand, are far less robust. There is data, I will come to that later. There is data on benefits of glucose control, but control of blood pressure and LDL cholesterol are probably more important as far as prevention of coronary artery disease is concerned. Patients at the highest risk should be on an AC inhibitor, independent of their BP. Even if they are normotensive, they should be on AC inhibitors because there are trials to show that they not only reduce the renal endpoints, but they also reduce the cardiovascular endpoints. Aspirin is no longer recommended for diabetes without established atherosclerosis. So no aspirin for primary prophylaxis, but definitely aspirin has an important role in secondary prophylaxis. In very high risk ASCVD risk, some people do give aspirin if the patient has a very low risk of bleeding. But that is a controversial topic. Maybe you'll have to discuss with the patient. Depending on the bleeding risk and depending on the thrombotic risk, maybe you can start on aspirin in very selected individuals. But in general, no, as far as primary prophylaxis is concerned. So lifestyle modification, re-emphasizing no smoking, more than 150 minutes aerobic activity weekly, weight control, healthy diets. Treatment of dyslipidemia is probably the most important as far as reduction in cardiovascular disease is concerned in diabetes, because there is data after data, large, strong data, class 1, level of evidence A, to show that it reduces cardiovascular events, both in primary and in secondary prevention. And this has been consistent. All trials uniformly have shown that treatment of dyslipidemia reduce cardiovascular events. The 2019 European Society of Cardiology guidelines say that in patients with moderate CV risk, that is, the young people, no other risk factors, no target organ damage, less than 10 years duration of diabetes, they should have an LDL cholesterol of less than 100 milligram per deciliter. Whereas the high-risk individual requires an LDL cholesterol of less than 70, and I have underlined that and because you should have both. It is not or. You should satisfy both the criteria. LDL cholesterol should be less than 70, and there should be an LDL cholesterol reduction of at least 50%. So if the baseline LDL is 100, you should get an LDL of less than 50. Less than 70 is not sufficient. In very high risk, the LDL cholesterol is less than 55. And again, an LDL cholesterol reduction of at least 50%, which in turn means that all high risk and very high risk diabetes should be receiving high intensity statin, because only high intensity statin can reduce LDL by 50%. So all these patients should receive high intensity statin irrespective of baseline LDL levels. Whatever the baseline LDL level, all these patients should be on either 40 milligram or 80 milligram of atorvastatin, or 20 milligram or 40 milligram of rosuvastatin. These are defined as the high intensity statin therapy. In moderate risk patients, of course, you can decide on what statin to give depending on the baseline LDL cholesterol. If the baseline LDL is 200, since you want to reduce it to less than 100, you will require high intensity statin, which will reduce by 50%. Whereas if the baseline LDL is maybe say 130, you require only moderate intensity statin. So in moderate risk patients, you can decide on the intensity of statin therapy based on the LDL cholesterol level. Now, if you cross the Atlantic and come to the American College of Cardiology guidelines, not much difference, basically the same. 40 to 75 years diabetes, LDL cholesterol more than 70, you should not calculate the 10-year ASCVD risk because they are high ASCVD, and you should put them on moderate intensity statin therapy. That is, if the LDL is more than 70. Whereas in higher risk people, or people with multiple risk factors, 50 to 75 years, they should all be on high intensity statin therapy. And if the 10-year risk is more than 20%, you are even justified in starting combination treatment of ezetimibe plus maximally tolerated statin, because you want to reduce by LDL cholesterol by more than 50%, and maximally tolerated statin will only reduce it by 50%. So in a 10-year ASCVD is more than 20%, you are even justified in starting a combination treatment. Of course, the indication is only class 2B, but still there is an indication like that. What about younger people, 20 to 39 years? This is American guidelines, 20 to 39 years, initiate statin based on what they call diabetic specific risk enhancers. This is very important to understand, because if any of these things are there, the risk goes up, the risk of cardiovascular disease goes up, and you may have to initiate statin. This includes long duration of diabetes, more than 10 years for type 2 and more than 20 years for type 1. Albuminuria, more than 30 microgram of albumin per milligram of creatinine. EGFR less than 60 ml. Retinopathy, neuropathy, or an ankle brachial index of less than 0.9. So if any of these things are there, even if they are young, only 20 to 39 years, please start them on statin. What dose you can decide depending on the patient's LDL cholesterol. What about the elderly above 75 years? Because there is now some controversy that people above the age of 75, benefits of statin in primary prophylaxis is questionable. Not in secondary prophylaxis, in primary prophylaxis is questionable. So what about diabetes? Well, if the patient is already on statin therapy, it is reasonable to continue statin therapy. If the patient is not on statin therapy and has already crossed the 75 without any cardiovascular event, which means it is primary prevention, the benefits are questionable. Maybe you should discuss with the patient and arrive at the potential benefits and risks and start the treatment depending upon the discussion that you have with the benefit. Because if he has reached 75 years without an event, how much benefit statin will give is really questionable. From lipids, let me now come to blood pressure, hypertension, and diabetes mellitus. About a third of people with diabetes have hypertension at the time of diagnosis. As time passes on, more and more people will become hypertensive, with the result that at the end of the day, almost 2/3 or 80% are hypertensives, or diabetes are hypertensives. But at the time of diagnosis, about a third are hypertensive. For any given blood pressure, even low blood pressure, say 120 millimeters, even at that blood pressure, diabetes have a much higher risk of CV-related mortality. The mortality risk when you have diabetes and hypertension is 2.5 times higher than those without diabetes and hypertension. And there is a strong relationship between systolic BP and the incidence of a variety of cardiovascular events in diabetes. As you can see here, even less than 120 systolic BP, at all levels of systolic BP, you can see that the blue that is diabetic towers above the yellow that is non-diabetic as far as CV mortality rate is concerned. Even 120, 120 to 139, even those areas you can see the diabetes have a higher mortality compared to non-diabetes. And this is what I was saying, tight glucose control versus tight BP control. You can see that stroke is significantly reduced with the red, that is tight BP control compared to tight glucose control. Even any diabetes related endpoint, tight BP control has much better reduction in risk compared to tight glucose control. Diabetes death, there is no difference. And even microvascular complication, there is a numerical superiority as far as tight BP control is concerned. So remember, BP control is very, very essential in diabetes. Steep graded association, as we have already seen, even 120, 130, when the patient's BP goes from 120 to 130, there is increased level of adverse cardiovascular outcomes. So the association is very steep between blood pressure, especially systolic blood pressure, and adverse cardiovascular outcomes. So your aim should be less than 130/80 in all patients with diabetes. Well, some people may not be able to tolerate this low blood pressure, especially elderly people. In those patients, maybe you can settle for 140/80, but aim for 130/80 or less, because that is what the guidelines say has the best result as far as prevention of CVD is concerned. Benefits of BP reduction are multifaceted. You can see that fatal and non-fatal myocardial infarction, 12% decrease per 10 millimeter reduction in systolic blood pressure. Fatal and non-fatal stroke, 19% reduction per 10 millimeter BP reduction. Microvascular endpoints, 13% reduction per 10 millimeter BP reduction. Even peripheral vascular disease, amputation or death, 16% reduction. And heart failure, significant 12% decrease per 10 millimeter reduction in systolic blood pressure. In fact, the only diabetic related endpoint which is not related to BP is cataract, where of course hypertension does not affect the rate of cataract extraction. Now, as I said, if you have blood pressure and something else, the risk goes up. Look at this chart. Very interesting and very striking chart. You are looking at the estimated 10-year rate in the y-axis, men and women who has perfectly normal blood pressure, cholesterol 200, HDL 50, no diabetes, no cigarettes. Now you add one risk factor, which means the blood pressure has gone up to 140, cholesterol has gone to 240, the rest the same. You can see that men, it has become more than double, almost triple, 13 has become the 10-year rate, and women, it is 8. Add diabetes mellitus, you can see this jumping up to 25 in men and 20 in women. And now you add smoking also, and you can see the event rate has gone up to 37 and 27. So as you add more and more risk factors, the risk also, CVD risk also goes up. So that is what I initially said. It is essential that one should have a holistic view of diabetes and treat all risk factors aggressively and globally. More importantly, it is very, very difficult to control BP in the diabetes. See, these are people, the black is controlled BP and the shaded is uncontrolled BP. If patients do not have metabolic syndrome or diabetes, even then you can see it is only 46% who have controlled hypertension. Now, if you have metabolic syndrome but no diabetes, the control rate drops down to 27.6%. If you have diabetes but no metabolic syndrome, it is again around 22.3%. And if you have diabetes and metabolic syndrome, a whopping more than 90%, 96% almost have uncontrolled BP. So diabetes is an important cause of uncontrolled blood pressure also. AC inhibitors and ARBs are the cornerstones of therapy. In fact, all diabetic patients with hypertension should be on either of these drugs because they have effects not only in nephropathy, but also in cardiac outcomes. If you look at the data, ACEI has more data as far as cardiovascular disease outcomes are concerned. The ARB data is much less robust, But in nephropathy, the data is equally strong for both ARBs and ACEIs. So cardiologists in general prefer ACEI, but ARBs are fine. If the BP is not controlled, most of the time it is not controlled with ACEI alone or ARB alone. You are justified in adding CCBs, diuretics, MRAs in that order. And maybe the next you can add beta blocker if the BP is still not under control. Aspirin, I have already said, the ADA and AHA recommend daily aspirin only for those patients who have established ASCVD, that is secondary prevention. Use of primary prevention is no longer recommended, may be considered a very weak indication in those at the very highest risk after considering their bleeding risk. Let us now come to glucose control. Though I have said glucose control is much less than BP control, benefits are much less than BP control, there is no doubt that glucose control is important because most of the microvascular diseases are determined by glucose control. Not only that, we are talking only about intensive versus less intensive glucose control. So an HbA1c of 9 or 10 is definitely bad for the heart. But glucose control is important even for coronary artery disease. The question is only about intensive blood sugar control. Maybe an HbA1c of 6.5. One has to be careful because it produces hypoglycemia, and hypoglycemia can be dangerous. So what we do, the current recommendation is that you divide diabetic patients into two groups. One is the UKPDS type of people. They are young, newly detected, no comorbidities, no established cardiovascular disease, atherosclerotic cardiovascular disease. And group 2 is the other extreme, elderly, long-standing diabetes, multiple comorbidities, hypertension, CVA, renal failure, and established atherosclerotic cardiovascular disease. Because the question to be answered is, how are they going to respond to hypoglycemia? The group 1 may respond well. They may be having some little problem, but they will get out. But the second group can even die due to hypoglycemia. So in the second group, we would like the blood sugar to be a little high than in the hypoglycemic range. The UKPDS post hoc analysis and long-term observation from UKPDS. UKPDS, mind you, included young, newly detected diabetes patients. They found that more intensive glycemic control is safer and more favorable cardiac effects, cardiovascular effects earlier in the course of diabetes, particularly without prevalent cardiovascular disease. When the UKPDS trial ended at the end of 5 years, there was no benefit with glucose control. But when the data came after 10 years, there were favorable cardiovascular effects. So that is important. Intensive glycemic control in the younger patient is good at the end of 10 years. And that also tells us about the metabolic memory, because the intensive glucose control in the first 5 years produced benefit at the end of 10 years. So there is a memory, the metabolic memory of the intensive blood sugar control in earlier periods. So young patients aim for an HbA1c of more than 6.5 or maybe less than that. But in the other group, the elderly people at increased risk, 3 major trials, advanced Veterans Association trial and Accord showed that actually strict glycemic control increased the mortality. And the reason is supposed to be hypoglycemia. So in these patients, go for liberal hypoglycemic target, maybe around 7, definitely not less than 7. 6.9, 7, 7.1 will be good enough in these patients. Very elderly, high burden of underlying comorbidities and prevalent cardiovascular disease. Well, no talk nowadays in 2023 will be complete without talking of SGLT2 inhibitors and GLP-1 receptor agonists. These are the first 2 hypoglycemic drugs which have shown benefit as far as cardiovascular endpoints are concerned. So far, we had suspicion that metformin may be good, but still the data was not very strong. But here we have 2 drugs which have strong data that they affect cardiovascular system in a favorable way. SGLT2 inhibitors reduce the incidence of heart failure. And now actually it has been found that it is useful to treat heart failure patients even without diabetes. So I would say SGLT2 inhibitors is now a heart failure drug which produces some hypoglycemia also. So that is where SGLT2 inhibitors stand now. GLP-1 receptor agonist, on the other hand, reduces vascular events, reduces stroke and reduces myocardial infarction. So GLP-1 receptor agonist will have a more long-term benefit on atherosclerosis, whereas SGLT2 inhibitors have a short-term benefit on the hemodynamics in heart failure as well as renal failure. So they have two different aspects to this drug. One prevents heart failure and renal failure in the early periods. The other prevents stroke and myocardial infarction in the longer period. But these two are really revolutionized the treatment of diabetes mellitus. Well, one question most people ask is, well, we all know coronary artery disease is very bad for the patient. And as someone said, many patients have silent ischemia. So should we not screen all coronary artery disease patients for all diabetic patients for coronary artery disease, even if they have no symptoms? It is a little controversial, but there are no guidelines, no evidence that screening will improve the mortality or event rate. In fact, as we have already seen, there is a lot of patients who have silent myocardial ischemia. So the patient will be asymptomatic, and these people have a poor prognosis. But the question is the benefit of aggressive screening, finding out silent myocardial ischemia, and then what are you going to do? You are only going to treat their risk factors aggressively. Even if you detect silent myocardial ischemia, what you are going to do is to treat their risk factors aggressively. You can treat that even without detecting silent myocardial ischemia. So most people now believe what is important is not screening everyone, but what is important is treating everyone if you look at the society as a whole. So asymptomatic patients, most guidelines now do not recommend routine screening for CAD patients because it does not improve outcomes. As long as, that is very important, as long as CVD risk factors are, I should have added there, are aggressively treated. Whom do you test for coronary artery disease? You should test for those patients who have some symptom, maybe atypical, maybe typical. If he has some symptoms, you should definitely test them. If they have an abnormal resting ECG, definitely they should be tested for coronary artery disease. So screening of asymptomatic patients with a high CVD risk, even with a high CVD risk, is at present currently not recommended, because these high-risk patients should be receiving intensive medical therapy, aggressive risk factor control. And the aggressive risk factor control provides similar benefit as invasive revascularization, as several trials like Courage, BAR-E2D, and the latest ischemia trial has shown. So aggressive risk reduction is the key. Indiscriminate screening is not cost-effective. Now, there are several trials in diabetes mellitus, but I will conclude my talk by talking about one trial which I am always very fascinated about, which is known as the STENO trial. This is not a multi-center or a large study. It is a single-center study with just 160 patients, type 2 diabetes and microalbuminuria. What they did was what I have been saying all this time. They intensively controlled all the risk factors in diabetes versus another group where only conventional therapy was given. The mean treatment period was 7.8 years, but then even after stopping the study, they followed up the patients for another 5.5 years, which means 13.3 years of follow-up. So the importance of this study is the long duration of follow-up. You hardly get a study where a patient has been followed for 13 years. Usually it is 4 years, 5 years like that. This is 13.3 years of follow-up, and the fantastic follow-up, because only 3 patients withdrew from the follow-up. So nearly 100% follow-up, only 3 patients out of 160 withdrew. So you can see it is about 96, 97% of follow-up. As I said, targeted, intensified, multifactorial intervention on modifiable risk factors for cardiovascular disease, diabetes, microalbuminuria. Primary endpoint, death from CV causes, non-fatal MI, non-fatal stroke, revascularization and amputation. And you can see everything has come down in the intensity therapy. Glycated hemoglobin has come down, systolic blood pressure has come down, diastolic blood pressure has come down, total cholesterol came down, LDL cholesterol came down, triglyceride came down, and the results are there to see. Conventional therapy versus intensive therapy at the end of 7.5 years, 50% in the conventional group versus just 25% in the intensive therapy. 50% reduction in the primary composite endpoint by this intensive treatments. Now, after another 5 years, that is around 13.5 years, the follow-up is, the trial has ended. So you can see the dotted line are after the trial has ended. You can see actually the curves are falling together. Glycated hemoglobin was almost similar in both groups. Systolic blood pressure, diastolic blood pressure is similar in both groups. Total cholesterol, LDL, triglyceride, all of them are almost similar in both groups by the end of 13 years. Because the conventional therapy people, after the publication of Steno 1, that is at the 7.8 years, the physicians learned that this is good and they probably put it into practice. And so even the conventional therapy people after the study has a reduction in all these parameters. But look at what happens. This is what is called metabolic memory. The first 7 years of aggressive control showed benefit even at the end of 13 years. The cumulative incidence of death, you can see, is significantly reduced in the intensive therapy at the end of 13 years, in spite of the fact that at the end of 13 years, the parameters were almost same. And cumulative incidence of cardiovascular event story is the same. Significant benefit with intensive therapy. You look at whatever endpoint you want, death from cardiovascular causes, stroke, myocardial infarction, CABG, PCI, revascularization, amputation, nephropathy, retinopathy, autonomic neuropathy, peripheral neuropathy, name whatever you want. Everywhere you can see that the intensive therapy is much lower than the conventional therapy. But look at, even though it was a good study, it showed immense benefit. Did they attain the target that they have wanted to? Look at, these are the targets that said at that time. Glycated hemoglobin less than 6.5, cholesterol less than 175, triglyceride less than 150, systolic blood pressure less than 130, and diastolic blood pressure less than 80. Glycated hemoglobin was attained in only about 20% patients. Cholesterol less than 175. We know now that it is also high in about 80%. Triglyceride again 80%. Systolic blood pressure a paltry 30%. Had it below 130. Diastolic blood pressure, again, about 70%. So imagine what would have happened if more people could attain these levels. Maybe the whole coronary artery disease would have disappeared from the diabetes group. And this is most striking. Only one patient actually in the intensive therapy group reached all 5 treatment goals. In spite of such bad parameter achievements, risk factor regression, just the intention to treat, you can see, has produced such significant benefit at the end of 13 years. But there is good news. There is light at the end of the tunnel. The Swedish National Database Diabetes Register showed large registry, 271,000 diabetes and 1,355,000 control, followed up for 5.7 years, looked at just 5 risk factors: HbA1c, LDL cholesterol, albuminuria, smoking, blood pressure. Type 2 diabetes subjects, remember now, who had these 5 risk factor variables within the target range, no significant risk of death, MI, or stroke. So as I said, maybe cardiovascular disease is almost same as a non-diabetic if you can bring these 5 risk factors under control: HbA1c, LDL cholesterol, albuminuria, smoking status, and blood pressure. Except maybe albuminuria, all the other 4 you can see are eminently treatable. But of course, all is not well, because death is reduced, MI is reduced, stroke is reduced. But what I have been saying always, heart failure is not reduced. The risk of hospitalization for heart failure continued to be high. That is what I said. It is heart failure and renal failure that are going to be the problems in the future as far as diabetes is concerned. So diabetes and heart, I would take a word from the conclusion of the Steno 2 trial, should be a target-driven, long-term, intensified intervention aimed at multiple risk factors. All are important. You should have a target for the risk factors. It should be long-term, not stopping with a year or 2. It should be intense, and you should aim at multiple risk factors. So reduction in diabetes complications stands on 4 pillars: glycemia, blood pressure control, lipid control, and finally the new drugs, SGLT2 inhibitors and GLP-1 receptor. And of course, the foundation should be strong. And the foundation is lifestyle modification and, of course, diabetes education. So to conclude, Mr. Chairperson and my dear friends, diabetes management, remember, neither begins with blood sugar control, because cardiovascular disease begins even before the blood sugar starts going up, that is in the pre-diabetic, nor does it end with blood sugar control. Have a holistic view of diabetes mellitus and control all risk factors aggressively. That is the only way how we can manage this epidemic which is gripped Kerala and even India, maybe all of the developed countries, India, China, all these, developing countries are having an epidemic of diabetes mellitus. And the only way is to have a holistic view of this disease. Thank you very much.
Thank you very much, sir, for that comprehensive and lucid talk. As usual, all your slides end with a consensus or conclusion statement, which actually drives the point straight to the heart. For that matter. Thank you, sir, for that. I think we will have some discussion. Sir, I will start the ball rolling. I just want to put a simple clinical scenario. A 36-year-old male came with a newly diagnosed diabetes, and his LDL at that time was 164. So I told him we have to start drugs for diabetes and cholesterol as well. But he said, no, doctor, I have not been at control at all. So I will do some lifestyle changes, diet modification, and I will come after 3 months. So after 3 months, his sugar was okay, but his LDL came down to 125. Now I have two questions, sir. One, what should be the baseline LDL that we should take into account in this patient? And second, what is your choice of statin in a diabetic patient?
See, there are 2 points here. One, we all know, I mean, the lifestyle modification is more often very good, very, very easy to advise, but difficult to follow. I'm sure this patient had aggressive exercise, aggressive diet control during the 3 months, and he is not going to follow it for his lifetime. There is no question about that. So I tell my patients, actually, you follow the lifestyle management. What you think you can continue for your lifetime. There is no point in doing for 3 months. I'm sure after 3 months, his LDL will be back to 164. Maybe his sugar also will be high. So what I will do in this scenario is, if the cholesterol is only 124, I will start based on LDL, 124, and put him on maybe moderate intensity statin. I am sure after 6 months, he will come back and the LDL will be around 130 or 140. And then maybe he will be more convinced that he should require a high intensity statin. As far as the choice of statin, I don't think there is any difference between rosuvastatin and atorvastatin. What is important is the intensity of statin treatment.
Thank you, sir.
Would you want to comment on the use of oral anticoagulants, small dose oral anticoagulants with antiplatelets that has been talked about recently?
Yeah, you are talking about rivaroxaban 2.5 milligram PD,
exactly,
where there are some studies. Now, this of course, when you add rivaroxaban to aspirin, there is increased risk of bleeding. So you have to balance the risk of bleeding versus the benefits that you get. I would follow the European Society of Cardiology guidelines. What they say is that the first criteria is there should be diffuse coronary artery disease. So that is most important. You think about adding rivaroxaban only in those patients who have diffuse coronary artery disease. Plus, you require something. That plus can be diabetes mellitus, can be polyvascular disease, which means peripheral vascular disease or stroke or something else, could be renal failure. So something else in addition to diffuse coronary artery disease, which could be diabetes, no doubt.
We have Dr. Balachandran sir who has joined in. Sir, your comments.
Good evening, Dr. Balachandran sir.
Sir, you can unmute yourself.
I don't think we have met post-COVID.
And it was an extremely very good, very lucid talk by
Thank you.
Govind. Unni, as usual, Unni is one of the finest speakers I have ever seen in Kerala. And there are a few points which we discussed in the last Rssdi meeting. This one is the non-conventional risk factors, what we called as a triglyceride, ApoE. There are some non-conventional risks, not the usual conventional risk factors. Non-conventional risk factors are supposed to have a greater predictability compared to conventional risk factors. That's why we try to measure triglyceride, lipoprotein, little a, ApoE, and ApoB, all those ratios and all that. That is one point. Second thing is diabetic patients are supposed to have a smaller block and rupture-prone block. So when you do a TMT or angio, they may be futile. You will not be able to say this patient's may go in for a myocardial infarction. Same night, you say the TMT is finished 13 mets and the angiogram is only showing 30%, but he may be having a rupture-prone block. So the Masseri et al. In even way back in 1968 said that the diabetic patients have more rupture-prone block compared to the non-diabetics. And that is one of the reasons why before statin era, diabetes was considered as a coronary equivalent. Now that the incidence of coronary artery disease have come down after the statins, as Unni has already pointed out. And this is the rupture-prone block. That is is very important in diabetic patients. So when you do a TMT and angio, it may be futile in diabetic patients. That is one of the points. The rest of them, everything Dr. Unni has cleared, and he did a very good lecture and a very nicely placed lecture. Thank you, Unni.
With respect to the non-conventional risk factors, they help you to sort of upgrade the risk. Like, for example, somebody with a moderate risk stratification, he has a low lipoprotein little a, or he has a high triglyceride, you will jump into the high risk group. So the non-traditional or non-conventional risk factors help you to more fine-tune your risk stratification and thus naturally adjust your risk factor modification also. The second point, Dr. Balendran sir, is perfect. That is exactly the reason why routine screening is not recommended, because we really do not know how to screen. We may be finding coronary artery disease, but the event rate, when are you going to develop a myocardial infarction, is very difficult to say, because most of the plaques that rupture has sort of positive remodeling, which means the lumen will not be compromised. The remodeling will be outside the lumen. So if you do a coronary angiogram, it will be 20%. If you do a treadmill, he may walk up to 12 minutes, but he may come back in the night with a myocardial infarction. Yes. So that is perfect.
There's a question in the chat box. In relation to metabolic memory, was DCCT or its follow-up EDIC more convincing than STENO2? It's a question from Dr. Ashok Krishnan.
With respect to metabolic memory, I agree. All these data showed that. The only reason why I hit upon STENO2 is, as I said, because of the long follow-up, 13 years follow-up, and nearly 100% people were followed up. But I agree, all this, even UKPD has showed about metabolic memory. At the end of 10 years, there was significant benefit. So I think there is no question that most people agree now to metabolic memory, whether it is blood sugar control or blood pressure control or lipid control. The earlier you start, definitely the better. That is what finally, that is what it boils down to.
And the one more point which I would like to say is the beta blockers. And the beta blockers have got a compelling indication if there is an associated cardiovascular coronary artery disease, unstable angina, or post-myocardial infarction risk stratification, especially the beta blockers like metoprolol, bisoprolol, and carvedilol should not be withheld in diabetic patients. In fact, there are a lot of studies where people who have used beta blockers in diabetic patients, they do much better compared to the people who don't use beta blockers in diabetic patients when there is a compelling indications.
Very true. Very true. Very true. Patients with post-myocardial infarction, all the more heart failure. Beta blocker is class 1 indication. Whether you are a diabetic or not is immaterial. Beta blockers definitely have better prognosis. Heart failure and post-myocardial infarction, without doubt.
So I have one more doubt, sir. Actually, in the recent years, I have found that this resistant hypertension is becoming more common. So I don't know whether it is actually really common or probably due to the quality of drugs. A lot of people are taking Gen Rssdi drugs. So what is your experience regarding that, sir?
No, one other reason maybe is that more BP is being checked now. People are more aware, they routinely check the blood pressure. That may be one other reason. And the second reason, I'm not very sure about the Gen Rssdi drug has created, because some people on Gen Rssdi drug are fine also. But I agree, some people do not really tolerate. So I think the two possible reasons are, one is that more people are getting BP checked. And second is that our BP levels are come down. Now we want 130 rather than 140. So the levels are also coming down.
Thanks.
What about your comment about the non-albuminuric diabetic mellitus versus albuminuric diabetic mellitus in prescribing the ACE inhibitors and ARBs?
Now, albuminuria, it has been found that it is more a predictor of coronary artery disease rather than nephropathy. So if the patient is non-albuminuric, I am not very sure whether there is any role for ACA or ARB. Albuminuria suggests an early endothelial dysfunction, and that is the time the patient should be on ACA or ARB. Non-albuminuric, I think, is a parenchymal disease where I'm not very sure if there are any nephrologists, they can comment.
The same way, SGLT2 inhibitors, it is not the same as ACE inhibitors, because SGLT2 inhibitors can be given both in non-diabetic hypertensive and diabetic hypertensive. Especially SGLT2 inhibitors are used now. The recent this thing is the SGLT2 inhibitors, dapagliflozin, heart failure, even for heart failure, reduced in preserved ejection fraction. It is the only drug now we have drug for preserved ejection fractions.
And you can give it up to 20 ml, GFR of 20 ml,
Yeah.
which I don't think ACEI, those people will tolerate if the GFR is 20.
Any comments from Jayakumar sir? You can see Jayakumar sir on the screen.
I think we have another question in the chat box. In a diabetic patient with no CAD, if statin is started and LDL becomes normal, then can statins be stopped at some point of time?
Never.
I think definitely not. It is like stopping anti-diabetic drug when the blood sugar comes under control. It is either lifelong or don't start that at all. In such totally asymptomatic patient, diabetes, when you start on statin, I always warn the patient, you be prepared to take it lifelong, otherwise don't take it. Why spend money for statin for 3 months? It's not going to benefit anybody.
No, sir, in that case, may I ask you one thing? Like, suppose if a person has taken statin for 5 years and then stopped, like, will he be in a better position or a more advantage than a person who has not started at all?
I don't think there is any data for that. But if his cholesterol goes up, theoretically, at least he must be at a higher risk. That 5 years of statin, like this metabolic memory, whether it will help, I am not sure.
Yeah, that's what I was asking, whether there is any metabolic memory or vascular memory in that case.
I'm not very sure. There is no data.
There is a concern regarding the adolescents. You know, we see a lot of patients between the age of maybe 18 to 22 who have dyslipidemia, who have a bit of deranged transaminases, which also puts them at a higher risk of eventual diabetes, a borderline high blood pressure. So what do you think about statin therapy or addressing those issues in those people?
No, in those people, I think it is basically a question of lifestyle. So I think that is what we should concentrate upon. Especially in a girl, I will not give statin because there is no trial of statin in pregnancy. So even if you are planning to become pregnant, the recommendation is you stop statin. So I think there you should concentrate more on lifestyle rather than medical treatment. Maybe they require quite a good number of people may even require some psychology counseling. These teenage obese people, I think it is what you said is correct. It's definitely a big problem.
In 1978, when I was doing the post-graduation, and we were talking about the substrate metabolism, free fatty acid, arrhythmias, and all this sodium pyruvate solution and all that. So now the same concept is coming with the HDL2 inhibitors, which acts on the substrate metabolism and delivers ketones instead of free fatty acid, thereby increasing the myocardial performance. So your comment about it, we don't.
No, that is one of the theories that it may be giving ketone bodies. To be very frank, we really do not know why SGLT2 inhibitors such immense benefit each individually, each of the theories individually actually really cannot explain the benefit that you see. So I think there is something which we are missing. There is a gap which we have to find out. Why the benefit of, because if for that matter, trimetazidine does the same thing. Of course, it does not produce ketone body, but it is a free fatty acid blocker. But that does not produce much benefit. It is more theoretical benefit than practical benefit. So there is some gap in knowledge in SGLT2 inhibitors. Nobody, when the trial started, nobody thought that it will have any cardiovascular benefit. It was a pure anti-diabetic drug.
There is another question which is practically very relevant. It has come in the chat box. Any role for minimum dose of statin, like 5 milligram alternate days, etc.? Because you see a lot of patients like that. When we ask about whether they are regular with statin, they tell that that is something which we daily hear from our patient.
No, there is no data to give half the alternate day 5 milligram. There is no data at all. So if you go by evidence-based medicine, you cannot follow that.
There is a question in the chat box in relation to metabolic memory. Was DCCT or its follow-up EDIC more convincing than steno? Of course, definitely DCCT and EDIC are more convincing than steno because it was conducted on 1,444 patients of type 1 diabetic, 6 years old. They were given insulin 4 shots a day, 6 times blood sugar measurements over a period of 7 years. So it is really one of the, that you cannot imagine to conduct a similar study like DCCT. So that is the one which throws light on us about the metabolic memory. After that only we came UKPDS and other things came. But DCCT is a convincing study on the aspect of metabolic memory, or what we call it as a legacy effect.
As a primarily, actually, we cannot compare like steno and EDIC. I mean DCCT and
one was only blood sugar.
There is primarily targeting blood sugar. This is multiple risk factors in those patients who have got microalbuminuria. And intensive control and a long follow-up, what is the outcome in that case? Cardiovascular outcome, basically. See, in that case, we can't compare those studies. There is a different levels.
Different populations.
Yeah, of course, when you look at exclusively for metabolic memory in glucose control, definitely, because those trials will be I think probably better evidence for that effect, metabolic memory effect.
So I would like to ask one final question with respect to the cardiovascular health of doctors. So that is something which we were all concerned for the last few years. We are seeing many young doctors getting sudden cardiac deaths. We don't know whether it's arrhythmia or it's atherosclerotic event which is causing the death. Recently, there was one study which was conducted on doctors from the state from Trivandrum, which showed that 84% of the doctors in the state are obese or overweight, and almost 46% of them had one comorbidity like hypertension, heart disease, diabetes. So your views and your advice on that.
No, I think the doctors, even if you look at the SSS1, SSS2, etc. of the IMA data, people who die, doctors die around between 60 and 70. Once you cross 70, I think you are safe. Then you go for a longer way. I think we have to understand basically that the whole world is not on our shoulders. It is very important. I think we should work like the West. We work from 8 to 4. After 4, if anybody comes, even if it is my patient or your patient, the concerned duty doctor will look at the patient. That is what everywhere across the world, that is what it is done. But here, every time, every patient wants his own doctor to see. And patients want his own doctor to see because the doctor goes and see. So I think we should make a move and say that we will not see patients out of office hours. It is difficult in the beginning, but someone has to take a first step forward. May not be very palatable to layperson, but I think from our point of view, it is correct that we should stick to some schedule rather than being on 24-hour duty.
It's our own choice. We have to choose, no, sir? Yeah. It's our health. It's our life.
And we don't understand the stress. That is the problem. We don't understand what stress we are going through.
Exactly.
Sir, one question. if we follow up the patient with diabetes, we see after 5 years or so, if we subject the patient to echo, we get the report as diastolic dysfunction in most of the patients. So how do we prevent this occurrence of heart failure in this patient?
No,
Preserved ejection fraction.
This diastolic dysfunction and diastolic heart failure are different. Most patients who are elderly or who are hypertensive or who have diabetes, they will have some amount of abnormality in relaxation, which is what they write as diastolic dysfunction. That is not diastolic heart failure. Diastolic heart failure occurs, or heart failure with preserved heart ejection fraction occurs at the extreme of diastolic dysfunction. Right now, if you ask me how do you prevent heart failure with preserved ejection fraction, the only answer is control blood pressure properly. Right now, the only treatment for prevention is control of blood pressure. For treatment, as Balayendran sir said, SGLT2 inhibitors have been found to be there. But if you are talking about prevention, the only treatment now is control your blood pressure.
What about the early introduction of AC inhibitors?
Early AC inhibitors have not really shown benefit in heart failure with preserved ejection fraction. It is only in reduced ejection fraction.
Okay.
So if there are no more questions, I think we'll conclude the session. So over to Dr. Prashant for the concluding remarks.
Thank you. Thank you very much.
So thank you, one and all, and thank you, Govindran sir, for that wonderful discussion as usual, wonderful session, and the discussion which followed was even more fruitful. And we also had good information which was given by Balachandran sir and the other panelists who were involved in this. And I thank the chairpersons also for starting off the discussion and having a very good 1 hour of engagement. And we would like to tell that Rssdi is having its annual meeting in March 18th and 19th at Ernakulam IMA House, Cochin. And I would like to invite all the participants to this annual meeting of Rssdi. And I would like to also inform all those who have participated to take the membership of Rssdi. Anybody who has not been the member of Rssdi, kindly take the membership, because there are a lot of good things which is going on inside Rssdi, which may not be available for those members outside Rssdi. I think Chandni Madam, our chairperson, has joined. Madam, some words from you.
It's always interesting to listen to Govindran sir, because I just
words of wisdom.
I just couldn't start be here in the beginning because of some other engagement, but it's always nice to hear, and we look forward to future sessions from sir, and also Balayendran sir is always with us. And as Prashant correctly said, we want all of you to become members of Rssdi, so that this will continue, the session and learning and interactions will continue. And I thank the chairpersons as well, because they are also our great support always. Thank you, Govindran sir.
Thank you.
It's again reiterated why we are troubling you again and again this time.
Thank you, Unni, for your nice talk.
Okay, thank you very much. Thank you.
Thank you very much, sir. Thank you all.
Thank you.
Thank you. Thank you all.
Goodbye. Good night, everybody.
Good night.
Yeah, thank you all. We are closing here.
Yeah, Kalina, just after this event, no, the recorded version should be sent to rssdikerala@gmail.com. I just forwarded that email. Okay.
Sure, sir. Sure. We'll do
We need to upload it in the YouTube channel. That's what as usually we used to do.
Okay, sir. No issues. We'll forward it to you on the mail.
One thing which I was a little disappointed that, see, this time our participants were almost half of what we had last time. When we were doing
any issues that they have faced, sir?
I don't know why, because maybe it's a platform change. We used to promote it around we used to and we expected I really expected a bigger crowd here. This is at least surpassing 100. That's what I expected, and I was a little bit disappointed.
So like it would be great, say, if we could get some feedback from the attendants, said that they have faced any issues or like any feedback that we can imply on our service.
Maybe most of actually we had faced this same problem once when we had insisted on registration. You remember, Prashant, once I had actually created that registration compulsory, then the number of participants was much lesser. Whereas we have, if we are not insisted on registration, suddenly I think probably what you call like instant joining were much higher. The moment somebody like remember this event and then going to click the link, when they say the registration requirement, then they leave it and go for something else. So that's what actually happening. So inviting more attendees, I think probably you have to avoid that registration link.
So like we have enabled that registration as after this session, if you want us how many have joined and who have joined, we need that information. And second one is
during the event we can make out how many have joined. We know who all joined. We can take a screenshot of the participant and keep it, so we know that who all joined.
Like sometimes they leave, join. So we need a data record like who are joining. And as this doctor space platform, we don't
actually it is always better to have more participants than less participant with definitive numbers and IDs.
Okay, so like we always try to make it segregated that nobody like not from a doctor non-doctor's background shouldn't be joined there. So like we try to maintain a form or dignity. So that's why there's some basic information.
That's our concern as well. But we only send it to doctors so that they join, and other non-doctor people are not interested in joining. They don't want to waste time by attending this thing. So then usually we don't see any such people. If at all somebody is attending, let them attend. What is it? We are not going to talk anything illegal or something we have to hide from the public or something. If they understand it, let them understand it. What is in the...
Like if they misuse the words, then it would be on our as illegal.
This is a scientific words that we are following the evidence-based literary this thing now presentations, not otherwise.
Okay, so yes, we'll take it as a feedback, and any other thing from the audience saying that they have faced any issues to join on a platform, would love to hear that.
Will be this registration form. I'm sure that is the only thing, because otherwise everything is the same. It's a Zoom link, the same thing that we used to send. Only thing is, I was insisting on that only once. I made it compulsory to make a registration, thinking that we will get an idea as to how many are going to join and all. But then the same thing happened. At the event, we had only around 40 to 60 people. Otherwise, we used to have nearly 100 people attending. And that time, we had only 40 to 60. At any point of time, there were only 45 people attending. So that is what. Here, this time only, we had 31.
Yeah, got it, sir. Your point. Surely, I will share this message to the concerned person.
So that the lowest in our last 8 episodes. Lowest.
Got it, sir. Sure, sir. I will share your message to the concerned department so that they can get back to you.
Yeah. And why do you? One other important point we noted in the TNC, you have put a clause that Clarinet reserves the right to modify the terms of use at any time without giving you any prior notice.
Yeah.
I didn't get it now. Can you please repeat again? I didn't get your point, ma'am.
So in the terms and conditions, you have put a clause. Clarinet reserves the right to modify the terms of use at any time without giving you any prior notice. So nobody would like to share their details like that, no? That's very obvious.
Okay, got your point, ma'am. Sure. I will send this one also as well to the department, ma'am, so that they can.
Without mutual consent, you can't modify the terms of use.
How can you say that's not fair, no? Because most of them are busy doctors and they don't want to receive things that they don't like to. So that we have to respect, no? And obviously people will think the data will be shared with somebody else, because many sellers need doctor's address.
Oh yeah, and they should not get any market calls or soliciting calls or something like that. That's also another problem.
Got your point, sir. No issues. We'll surely send those 2 points to our department so that they can look and we can modify, and so that we can get all of you on our platform again, sir.
Right.
Okay.
Thank you so much. Good night. Yeah.
Good night.